I'm Michael Battelle, President and founder of the Fatty Liver Alliance. We raise awareness about the risk, causes, and complications of fatty liver disease and help those already diagnosed with MASLD and MASH by advocating for access to approved treatments and care. Today, as part of our patient-focused series, Liver Insights, Illuminating the Path Through MASLD and MASH, I'm excited to introduce Dr. Maru Rinella, who's a transplant hepatologist. She's the director of the Metabolic and Fatty Liver Program and professor of medicine at the University of Chicago. Today, in part 8 of our special series for patients who have already been diagnosed with MASLD or MASH, we'll be discussing deciphering symptoms and what they mean, helping patients understand and monitor their symptoms effectively. Dr. Rinella, the biggest challenge with liver disease, and you know better than anybody, it's that it is so often silent and it has been hard to identify symptoms of disease for patients with MASLD and MASH. What are your thoughts and what should patients be aware of?
Yeah, so that's I think the critical point. It's a critical point because it's the main reason I think why patients don't seek care and why their physicians might not know that they have liver disease, even if they could even have cirrhosis and not know it. So I think what is most effective is to understand what the risk factors are for having scarring in the liver. And in this context, it's going to be diabetes, high blood pressure, and obesity, particularly medically complicated obesity, which is obesity plus complications such as hypertension, diabetes, abnormal cholesterol, triglycerides, et cetera. So the more we can link the sort of risk factors with the patients in their minds and knowing that that's what's going to increase their risk, I think that's an important step forward.
I think historically I've heard from patients too. The two things that I hear a lot are fatigue and also brain fog. I don't know, and it might have been more in the hepatitis days, but maybe you can talk about that. When you're going through a few of the slides that you prepared for today.
Absolutely.
Okay. Do you want to?
Okay. So what I'm going to do is just kind of walk you through elaborating a little bit on what I just mentioned. So Michael, thank you for setting me up so well. That's helpful. Okay. So firstly, I guess to start out with symptoms. So what kind of symptoms do people really have with the disease? And it really is, largely it's not specific at all, right? So if you see that here on this slide that 71% of people complain of fatigue, you might imagine that that is a very common symptom that's seen across different disease states and even in health, right? So we work too much, we don't get enough rest, et cetera. So that's really the predominant symptom that you're going to see. And the next most common, other than overweight's really not a symptom, it's really a finding, but abdominal discomfort, specifically right upper quadrant pain, occurs in this particular study in 44% of people, but I would say up to 60%. But usually they complain of this after they've been told already that they have steatosis or fat in the liver. So this nonspecific symptom profile is part of what makes this a difficult disease to identify and treat. So this feeds directly into a very low disease awareness, not just among patients, but among providers as well. There are, of course, disparities in access to care. There's a lack of clarity on identifying at-risk patients. There was for a long time, and in fact, there still is a lack of understanding of the perceived treatment options. So we now have an FDA-approved drug to treat patients with this disease with a bit more advanced fibrosis or scarring. But the truth is there's a lot we can do in addition to that by adjusting other medications. And the other major piece that I think is what is a barrier mostly for providers is that when the liver chemistry tests appear normal, and that's in quotes because there are subtle things that can tip you off that there's more scarring in the liver, they don't even think that there could possibly be advanced liver disease. And then, of course, stigma is an issue, a real issue for this patient population. So again, minimal side effects, minimization of the consequences by providers, telling patients it's just fatty liver. Today, again, I saw a patient who had been followed for 15 years with fatty liver and told not to worry about it and just adjust their diet, and now they have cirrhosis. So many of these things I already mentioned, and then the stigma bit as well. So this is an example sort of illustrating how little we are picking up people with advanced disease from MASLD and MASH. So this study is looking at claims from about 2 million insurance claims fairly recently. And you can see the amount of codes that are provided by providers themselves. It's about 200,000 using the NAFLD-NASH codes. However, if you extrapolate from risk factors, aggregate risk factors, you can see that the amount of people who likely do have MASLD and MASH is significantly higher, on the order of more than 16 million people. And these are people that are not being diagnosed or identified as having liver disease. The other thing that's really disconcerting is, just like my patient that I saw today, these diagnoses, when they do occur, they occur late, and they often occur at the same time as a decompensating event. And what I mean by that is, when the liver has cirrhosis and it doesn't work anymore, it starts to develop things like fluid accumulation in the belly, confusion, bleeding in the gastrointestinal tract, et cetera. So patients are quite sick by the time they're diagnosed. And that really has to stop, I think. So this is an algorithm that we put together for the American Association for the Study of Liver Disease guidelines. And we're not going to go through it, but just so that you see that we do have specific recommendations for primary care and GI and hepatology care with respect to how to assess a patient who either has steatosis or fat in the liver noted incidentally, or a suspected, this is suspected. And then to illustrate, not only has this been recommended by the American Association for the Study of Liver Disease, ASLD. It has also been reinforced and recommended by the American Gastro Association, by the European Association for Liver Fibrosis Stratification purposes, and also from the American Academy of Clinical Endocrinology as well, in a joint guideline that we did with them. So everybody is unified and aligned as with respect to the recommendations that we're giving providers to identify those at risk of advanced liver disease. And in fact, this is a paper that we did with several colleagues across the world, advocating for the implementation of a liver health check in people with diabetes. Patients with diabetes are extraordinarily high risk of advanced liver disease, and we overtly recommend screening in this population. And what we'd like to see happen is a normalization, or the fact that the liver is checked along with people's eyes, kidneys, et cetera. And when you have diabetes, that's what primary care doctors will do. In fact, we recommend specifically at the ASLD in our guidelines that we screen type 2 diabetes. Why do we do that? Because if you look at the background prevalence of advanced scarring in the liver, so this is really going to be pre-cirrhosis or cirrhosis, in the background NAFLD or MASLD population, that's going to be 0.9 to 2%. So if you compare that to what you see in diabetes, which is closer to 20% in most studies, that is a very significant increase in risk. Medically complicated obesity, or up to 30%. Moderate alcohol use, also a significant risk factor. And then if you have a family member, a first-degree relative with cirrhosis from MASLD or NAFLD, then you are at significantly increased risk for fibrosis as well, and those patients should be screened. And so again, the rationale is these populations are enriched with advanced fibrosis. Delayed diagnosis leads to significant morbidity, mortality, and cost. And we can do a lot for these patients. So there's off-label use of medications. And as we recently have heard, the approval of medication for people with MASH and advanced fibrosis. So fatigue, again, so as you saw, that's the most common complaint in patients with this disease state. And these are data from the Global Liver Disease Registry, which is a fairly large consortium that includes patients from all over the world. And you can see that on average, severe fatigue is occurring in somewhere around 28 to 34% of the patients in the study. And then medical history of fatigue, again, very prevalent in this population. So looking at other potential health-related or patient-reported outcomes, you can see here a very busy slide looking at various different metrics below. And again, the prevalence of significant fatigue is about 30%. So it's pretty common, but again, super nonspecific, and we certainly cannot rely on in this particular study. Females, those that have diabetes, history of depression, and other comorbid illness had a higher degree of fatigue. So the interesting thing is that the fatigue may be a predictor of mortality, or at least it was in this study that looked at some large US databases. And you can just see here the separation between patients with fatigue versus those without fatigue that have, over time have a lower survival probability. Again, this is very nonspecific, could relate to numbers of comorbid diseases, et cetera, and other concomitant issues. But again, it is an important symptom. So what should we do? This is an example of a project that I've been working on for a couple of years in conjunction with Michael Charlton and Stephen Harrison, both of which are experts in this disease as well. And what we're trying to do is reach the general public and reach patients so that they can do that first step in risk stratification, so that if they don't have access to a physician in their area, or their physician maybe doesn't understand how to do that, they can sort of nudge them along and help them a bit with that. So what we did here is we created essentially the components of a FIB-4 for those that have access to their blood tests. And if not, we have a simple liver health meter that can give you some risk stratification as well. And we provide various other services with this too. But what it basically does is, if you calculate your risk and it ends up being high, meaning greater than 1.3, you get a printout that you can then give to your provider and hopefully get the necessary care that you need. So just to close, MASLD is the most common cause of liver disease, certainly in North and South America, parts of Asia and the Middle East. Actually, as well as Europe. There are only some countries, some places in Asia and Africa where this is not the most common cause of liver disease. The symptom profile is woefully nonspecific, as are the laboratory tests. Again, most commonly fatigue and right-sided abdominal pain. We really need to increase disease awareness. This is absolutely critical, and understand our risk factors for advanced disease, because I really think that only by doing this, we will be able to put a dent in this major public health problem. And again, you need to be your own advocate, and participating in programs like this, and in patient advocacy organizations such as Fatty Liver Alliance, you really are moving the field and moving patients' well-being forward. So I thank you for that. And with that, I'd like to thank you for your attention.
Thank you very much. While you close, oh, there you go. First of all, I love the way that you told the story, and the HepVita program makes a lot of sense because it puts it back on the patient a little bit to take care of their own health in a very busy landscape. Physicians, sometimes it's hard to get appointments, or people are remote, and maybe it's almost impossible sometimes to find a primary care physician who can help you that way. But what you've convinced me of today, and probably people watching, is that the risk factors are really almost more valuable than the symptoms, because if they're so general, like you presented that the fatigue was, I think, over 30% or something like that. How many of us are tired all the time anyway?
Right,
It's
right,
probably in the general population at least that
right.
much. Maybe patients are more rested. I don't know, but so that's a tough one to be able to look at. And I think because there are those other comorbidities with type 2 diabetes and with obesity, there's also probably a higher rate of fatigue and other symptoms as well.
Exactly. It's
So,
hard to tease
yeah.
it out, right? And I figured the way I look at it, most everybody knows if they have diabetes. or they know if they're overweight and they know if they have high blood pressure, or at least if they're being treated. And by the way, some patients mistake good blood pressure control or good diabetes control with not having the disease anymore, right?
Mm.
And so if you are on medication to treat any of those diseases, you have that disease, right? And so that is a risk factor irrespective of how well it's controlled.
Well, what scares me the most is that, and your practice specifically would be sort of hyper aware of the fact that the patients who are unaware all the way until it's too late because they didn't either they weren't checked or assessed until right until like as you said they either have cirrhosis or they even need a transplant. So what's the reaction that you're seeing from patients when they come to you and it's like what? They have no idea.
Yeah, it's very hard because they could even be seeing a good doctor, right? And the problem is that they're not paying attention to, subtle things. And I think there's this very big misconception that fatty liver is no problem. And that's one of the reasons why we hope that as the SLD and MASLD nomenclature gets taken up a little bit more, it increases the seriousness of what it is, because it really is a metabolic derangement that can lead to severe diseases and problems and outcomes just like diabetes.
Mm.
So hopefully with time that will help that a little bit. But patients are shocked, and they are angry, and I understand that. And I try to explain that it's super common, that doctors don't realize that you don't have to have elevated liver enzymes. And the scary thing about it even is that as you get older, and you develop diabetes and the diabetes is worse, your liver chemistry tests actually are lower. So people with diabetes have a lower risk of having elevated liver enzymes, which then makes them even harder to
Right.
identify. So that's why if we can just sort of re-emphasize over and over that it's those risk factors that should set off alarm bells, that it would be, I think it would make a huge difference. I really do think it'll make a huge difference.
I'd like to focus on a positive point also and say that you have patients, I know because you've shared with me, that have had success once they've identified the fact that they have steatotic liver disease, that lifestyle management can help some patients with
Oh, yeah.
exercise or food and actually reverse some of the damage, right?
Yep, it can. It definitely can. So with, dedicated, changes in the diet, and sometimes they don't even need to be that draconian. Sometimes even just minor changes in the way you do things can really be beneficial. Even 5% weight loss can be really beneficial. And over time, that, those changes add up and you can end up with reversal in some of the scarring that you have in your liver. So it's not all lost if you have scarring in the liver, but you do need to, the earlier you get it, the easier it will be, and the more likely you'll be to reverse.
Okay, and
Um,
final note too to patients that if they do have some of the risk factors that you talked about, those other comorbidities, and they have never been assessed for liver disease, they should get assessed at least once. Is that what your recommendation
ab-
is? If they haven't,
yes,
yeah.
absolutely. We recommend primary screening in those at-risk groups because there's a clear benefit to doing that. So they should, and if their physician doesn't understand that that's important, they can pull up the guidelines and
Sure.
they can show them what the evidence is, and that is what we recommend formally. So.
Well, the work that you do every day and the work with the ASLD have really helped a lot of patients and patient care. And thank you for today and the time that you took to share some really great information and tools for people too.
It's my absolute pleasure. Thank you for doing what you do. So.
Thank you.